list. But I will tell you from a personal experience, when I was sitting on the COVID-19 task force, our first call with Dr. Piercey was about our first case in the state of Tennessee. And the amount of knowledge that she had already culled together to share with us, and the proactive approach that she and her staff and the entire governor's team have taken with COVID-19 was really impressive. And that drumbeat, I think, has continued throughout 2020. And here we are in 2021 and hoping we can look around those corners, work together, and provide comprehensive solutions for our residents of Tennessee. So with that, Dr. Piercey, thank you so much for your time and really appreciate all the hard work you've done.
Thank you, Holly. That was a kind introduction, and I appreciate the opportunity to speak to you guys today. Thank you, Bradley, for the invitation. And so I've jotted down some notes here that I'll go through. I'll keep an eye on the clock because there's a lot in my head that I want to be able to give to you, but I know we've got limited time and I want to save time for questions at the end. Before we, excuse me, before we talk about vaccine, I want to remind you about the virus. We've still got a lot of viral transmission here in the state. We have high positivity rates, which may not be something that you've looked at much or paid much attention to. Some places call those attack rates, but basically it's what percentage of tests that we're running are positive. Our current average is just north of 20%, approaching 21%. That may not mean much to you, but to give you some context, the White House defines a hotspot when it's over 10%. So we're more than double that. And about 75 of our 95 counties in Tennessee have positivity rates of over 20%. That tells us two things. One thing it tells us is that not enough people are getting tested. You know, testing is kind of like not the cool new thing anymore. People are like, yeah, I've had that. I don't want to do that again. And like, oh, I know what I've got. I've just got a cold or whatever. Or sometimes they know what they have and are not getting tested. But whether it's colonoscopy or strep screen or whatever, you need to test a broad enough swath of your population to know that you're capturing everybody that is positive. And when our positivity rates are in the 20%, we're not capturing everybody. The other thing that we look at, and the thing that tells us about positivity rate, is that people are sick. And when people have symptoms and the prevalence is this high in the community, they're very likely to have COVID. And so please don't lose sight of the need for testing, whether that's amongst your employees or your own family. Everybody's getting kind of distracted by this shiny new object we have over here in the vaccine, but let's not forget about the actual virus and testing and the importance of that. The reason that the virus is still very important and to focus on those numbers is because we are still in the midst of a massive hospital crisis right now. Our hospitals are overrun. And when you look at the numbers from a statewide perspective, and I'll stop here for a second and tell you, this is going to inform our vaccine plan. That's why I'm giving you this context, because it's very important when we talk about our hospitals. Right now, a third of all hospital beds in Tennessee are taken up with COVID patients, and half of all ICU beds in the state are COVID patients. That is a massive number. Right now, we have about 3,300 hospitalized patients statewide and 800 ICU. Those numbers may seem pretty small to you, but when you talk about half of all ICU beds and a third of all inpatient beds are COVID, that's a pretty big deal.
Commissioner?
I think I got muted.
You did. We were trying to mute everybody else, and it, yeah, my skills have not gotten as sharp, but we're very sorry. We probably lost about 30 seconds.
Okay, no worries. I bet my husband wished he had a mute button for me. But okay, so I'll back up a little bit. And so 30% of all inpatient beds are COVID. 50% of all ICU beds are COVID. Those may not seem like big numbers to you, and particularly if you look at the raw number of hospitalizations, 3,300, you're like, oh, well, We have 6.8 million people here. That's not that big of a deal. I have to tell you that in a typical winter, a hospital might have 85, 88, 90% occupancy in the wintertime. And then if you have a bad flu season, it can be in the low to mid 90s. And then you put this on top of that, you can quickly see what a huge strain it's putting on our hospitals. And you've probably heard me say this before, but you know, kind of the knee-jerk reaction that we hear when hospitals are full, like, oh, well, y'all have those alternative care sites. Just open up those field hospitals in Memphis and Nashville. Well, it turns out space is not the problem. Beds are not the issue. It's people to work at the bedside. Mostly nurses, but also respiratory therapists and laboratorians and physicians and all that kind of stuff. And so we don't have anybody to staff the alternative care site. We've got places to put patients. We just don't have staff to work there. As this group very acutely knows, we had healthcare workforce shortage prior to all of this. And given a lot of different factors, the illness, the disease itself, being recruited out of state or being travel nurse because of contract agency paying really well right now, we're really struggling from a healthcare workforce standpoint. And so I wanted to set that context because it really informs when we talk about vaccine prioritization. And if you hear nothing else I say today, I want you to develop this instinctual response. When you hear vaccine phase or vaccine priority, I want you to immediately think of the word risk. It's all about risk. And it's very, very easy to quickly start thinking about, oh, somebody's more important or somebody's more valuable or worthy. It's not that at all. It is absolutely, the entire prioritization plan is based on risk. And we categorize risk in 3 big buckets here in priority order. The number one, the first one of those, and it's pretty unequivocally aligned all across the country and probably the globe as well, is risk to the healthcare infrastructure. We have got to be able to preserve that very top level of highest acuity emergency care, and then we can funnel down from there. Because if you don't have a hospital or an EMS or emergency department and your leg gets cut off in a motorcycle accident, that walk-in clinic's not going to do anything for you, not going to be able to help you. So we have to preserve the infrastructure at the very top, and then it flows down from there. Well, how do we do that? One is supply of that infrastructure, which is workforce. We have to preserve that workforce. And the other is demand and reducing demand on that. So we'll talk about that in just a second. But the first bucket in risk is risk to the healthcare infrastructure. The second bucket is risk to individual health outcomes. And this is making sure we target vulnerable populations, those that are most likely to be hospitalized or to die. Now, this is the one, and as well as number 3, is where people start getting squirrely, because it's like, well, why is this industry more important than this one? It's not that. Remember, you need to be thinking about risk. And it's not a judgment call or a statement of value to say that a 71-year-old gentleman with COPD is more likely to be hospitalized and die than a healthy 28-year-old teacher. I don't think anybody on here disagrees with that. That's just what the data bears out. And not only have we seen that nationally and even globally, we're using Tennessee data. We're using what we have had. Unfortunately, we've had a good bit of experience with COVID in our state over the last 10 months. And we have very clearly seen that there's this really sharp drop off in hospitalizations and deaths under age 60. And you can slice and dice it every way you want to, but 65 plus accounts for more than half of all hospitalizations and 80% of all deaths. So when we target people based on risk, we target those based first on age and then also on comorbidities. We know, and I know everybody on here is aware of someone that is under 65, maybe even a lot under 65, that has had a severely poor outcome or death, and they weren't that old, probably because of their medical condition. And so that essentially also ties into risk. We'll get to that in just a second. The third bucket of risk is risk to society and economy based on who is at highest risk of exposure. So this is where it starts getting like who's more important than anybody else. I want to take a moment to distinguish between a couple of terms. And I hear these terms getting conflated all the time. And it was probably okay to do that in the spring when we were doing all the stay-at-home orders, but now it's a very crucial distinction. And I would challenge you, please don't conflate these terms or use them interchangeably. Those terms are critical infrastructure and essential worker. Those are not the same. Now, those got used interchangeably back in the spring because essential workers were still allowed to go out and go to work and those other kind of things. We never really had a focus on critical infrastructure back in the spring. But now, when we have a very limited supply of a very in-demand product, we have to look at what is most critical to our society and economy. I want you to think about things that, like, we wouldn't be able to function as a society if we didn't have these. It's not a nice to have, it's a have to have. So things like electricity and communications and food production, things that keep our society moving forward, but also our economy. Now, I know you know, and I hope you understand what a strong believer I am in what I'm about to say. I come from a family of small business owners, and my dad's a farmer. So, I mean, we're very attuned to how important all businesses are to the economy. But when you look at this funnel of how they work down, like look at K-12 teachers, so or K-12 instruction. Particularly when you get in the younger grades in the elementary school, that is something that everyone agrees is not amenable or certainly not ideal to remote learning. Likewise, if you have parents of kindergartners or second graders or whatever, and those kids can't go to school, the parents often can't go to work. That is a risk to our economy. And so that can be said for a lot of different industries, but specifically in that one, it's really impactful. If you want to compare K-12 to higher ed, one is not more important than the other, but you've got a couple of different risk factors. And I'm just using this as an example. It's top of mind because I did a call earlier this morning with a university president who wasn't particularly happy that higher ed wasn't in the bucket with K-12. A couple of different distinctions. Higher ed, faculty is up at the front. I mean, even in an in-classroom setting, far away from the students, very limited physical interaction. Compare that to a pre-K teacher or a first grade teacher who physically has to be in contact with students pretty commonly. Likewise, as I mentioned a minute ago, the learning environment in higher ed is much more amenable to remote instruction than K-12 is, particularly the younger grades. And so therefore, that is an example of a risk-based approach and an exposure-based approach to making these kinds of decisions. Now, something that makes our plan unique in Tennessee, and you probably heard about it when we announced a plan revision about a week ago, and it's our concurrent age-based approach. That's, well, I was going to say that's different than other states, but just to be frank with you, I haven't had time to go look at all the other states' plans. I know some kind of top themes and some highlights from some of my colleagues and other media reports, but I don't know that there are a ton of states that are doing this concurrent approach like we are. And for us, it is not just critical infrastructure or just age-based. We're doing parallel paths at the same time. Now, that would work a whole lot better if we had a supply chain that was pretty steady, which we don't. I'll talk about that in just a minute. But what that does is it helps us target those absolutely most vulnerable people first in order to reduce demand on our hospitals, which was in that very first bucket of risk that I talked about. I'm going to pause for vaccine talk just for a second and take a sidestep of something that's very important for you to know about. This group probably has heard of it, but the general public at large, I just really don't think is quite familiar. And that's monoclonal antibody. That is what we call a therapeutic, which another word for treatment, that can also reduce demand on hospitals. So you probably remember when President Trump and Chris Christie and Ben Carson were hospitalized, they got these, at the time they were experimental therapies, they now have EUAs attached to them. One of them is called Regeneron. The other one has a big, long molecular name that starts with the letters BAM, so people call it BAM. But either one of these are in infusions. It's an hour-long IV infusion. Then you have to be monitored for an hour. But the success rate of keeping people out of the hospital might be upwards of 90%. It is an extraordinarily effective tool. And when I talk to other physicians, these are the things we're excited about. Vaccine's great, that's good, fine. But I don't think there's a lot of public sentiment about monoclonal antibody. First of all, it's just difficult to say and even more difficult to understand. People are familiar with vaccines. They kind of can wrap their brains around that. They know what that means. But please tell your friends and family, tell your colleagues and your workforce that if you are diagnosed, and particularly if you are high risk, older or even younger, but with medical conditions, you need to go get the infusion. Like other treatments, sort of along the same lines as Tamiflu, you have a limited time to do that right after you are diagnosed. We have this product available in almost every hospital, certainly all of the large hospitals. And I don't mean to imply that hospitals aren't doing a good job, because we've got some all across the state that are doing a really, really good job. Actually, my former employer, West Tennessee Healthcare, was featured in the New York Times about a week and a half ago because they are doing several hundred infusions per week. And they realize, hey, we have to do this to keep people out of the hospital. And it's something that is very effective. It's available. We are only using a small fraction of the supply that the federal government has sent to us. And so availability is not an issue, but that is an effective tool that we can reduce hospitalizations. All right, back on vaccine, which is another thing that can reduce hospitalizations, albeit not in as short of a term as monoclonal antibody. The good news, here's a little fun fact about vaccine that you might not know. After 10 days, you're about 50% covered. And after 28 days, after the first dose, you're 90% covered. So you do need that second dose. What remains to be seen, and I'm sure you've heard the news in the UK, what remains to be seen is how long you can keep a 90+% effectiveness after one dose. It might be for several months. We don't know. We do know that duration of immunity, that second dose gives you duration of immunity, but the first dose gets you immune after 28 days. So that's the rationale behind the UK delaying second doses and getting more first doses out. It's a big risk, and the FDA has warned us we're not going to take that risk here, but it is something that helps us be reassured that even after one dose of vaccine, people become protected pretty quickly. So I'm very, very hopeful and prayerful that within the next 4 to 6 weeks, even though our population that has been vaccinated is still quite small, that we will start to see the tide turn. By no stretch of the imagination do I think this is a silver bullet, but it is a move in the right direction. So let me tell you a little bit about supply, and then I'll wrap up with phases and then take questions. So I want to reassure you that we are ordering every single dose that is made available to us. We are constrained by supply, everybody's constrained by supply through Operation Warp Speed. But now that we're sort of past the initial ramp up, we're in more of a regular cadence here in the month of January. So that cadence essentially, unless there is some type of unexpected aberration, the cadence is vaccine comes on Tuesdays, and then we can order on Thursday nights. So I don't know, I think it opens like at 7 or 8 o'clock tonight. We'll go in there, we will max out in every single category and to every single site. And we do that every time the portal opens. Then if nothing happens, that will ship it will ship on Monday and come in next Tuesday. The problem is that well, there's a lot of problems, but not problems, just challenges. So one of those is there is just not enough supply to go around right now. To keep it in context, remember, we just started this like 3 or 4 weeks ago, which means Pfizer and Moderna just started producing doses several weeks or a few months ago. Like any manufacturing process, they ramp up over time. And so that is a point of hope for us that their production capacity will ramp up over the next several weeks, but they're still in the very early infancy stages. The other thing we have to keep in context is Pfizer and Moderna are supplying the entire globe. It's not just America. So those two factors primarily are what is limiting our supply. Our supply here in Tennessee, our allocation is just on a per capita basis. So we're not getting any more or less per capita than any other state. We actually do it a little bit different when we distribute it in the state. You may have read about it. If you're interested in the details, there's a lot of granularity in our plan. We do allocate the bulk of our vaccine per capita, about 85%, to the counties, but we also add in what we call a social vulnerability index. So counties that might not have a healthcare facility, might have lower population, but are more at risk because they are impoverished, distressed, at risk. We allocate 5% supply to those particular counties. I can't remember the number off the top of my head. I want to say it's between 20 and 25 counties that have that SVI designation, and so they get a little bit extra to account for that potential inequity. So we get those on Tuesdays. There's one other thing that you need to keep in mind. So for the 4 weeks in January, we have to skim off the top of what we get and give it to CVS and Walgreens, and in some cases other independent pharmacies, our pharmacy partners, to vaccinate our long-term care facilities. And so if it looks like, of course, you probably have seen the headlines. I don't want to brag on us, but we're doing a pretty good job nationally at administering the doses that we have available to us. I think this morning we were 7th in the nation and had delivered 51.5% of our supply. And you may be sitting there going, well, that's only half of it. Where's the other half? About 40% of it right now is going to the long-term care partnership. That will happen with each allocation in the month of January, and then we'll return to our full supply being able to be deployed in the community in February. Finally, and then I'm happy to take questions, is what phase are we in? So we have a listing on our website of all phases by county, and counties might move through phases at different speeds. And that's for a couple of different reasons. One is, clearly, Davidson County and Shelby County have a much higher number of, and higher percentage, frankly, of healthcare workers than Giles County or Lewis County. So it's going to take them longer to get through that 1A1 phase than it would others. Likewise, uptake. There is a higher uptake in metro areas versus rural areas. Actually, the rural uptake is a little bit higher than we anticipated. We were worried it might be as low as 30%. It appears to be maybe closer to 50 or 60% in most places, but that causes them to move through phases faster if they have people who are offered it or are eligible and are just not interested and they decide to pass. So we'll continue moving through those phases. And then the final thing that I'll tell you before we open it up is, if you are interested, and I know many of you are because I've had some conversations with some of you about administering it on site at your place of business, you need to, if you haven't already, you need to make sure you are enrolled as a provider. That's on our website. CDC has a process that you have to go through with Operation Warp Speed. It's not difficult, it's just a lot of paperwork as per usual. And so make sure you're enrolled as a provider, so when it becomes that phase, we can go ahead and get you that vaccine, because we would love for you to vaccinate your own people. That way it is just more hands to help us with the work. So I'll stop there, and Bradley, I'm happy to, or Holly, I'm happy to take questions, whoever has them.
I'll start with a question, Lisa, and thank you so much for that just very thorough presentation. A lot of moving parts and a lot going on. When you talk about the 40% of that going to long-term care facilities, I'm guessing that means primarily assisted living, and your expectation, just to clarify, is that those individuals, which would be higher risk individuals, those that choose vaccination will be vaccinated by the end of the month, which then that supply goes on to the other priority categories.
That's right. So residents and staff of long-term care facilities are in 1A1, which is the very first category. Our state has about 90% participation in the CVS Walgreens federal partnership, the other 10% through local pharmacies. And so we're in pretty frequent, like multiple times per day, communication with CVS and Walgreens about the speed in which they deliver these. They've recently, as yesterday, rolled out some data on their own website, CVS in particular, and then I think Walgreens is coming online in a couple of days, to show exactly how many facilities and residents have been vaccinated. And last I heard, which was this morning, I think they had already gotten through 37% of skilled nursing facilities. I'll come back to that. 37% of skilled nursing facilities in the first 9 days. We have a lot of skilled nursing and long-term care facilities and residents here in the state. That's somewhat common in the South. We have a higher number of those than other places in the nation. But the reason I pointed out skilled nursing facilities, or sometimes called SNFs, and nursing homes, those are prioritized higher than assisted living, because if you look at risk of the population in a nursing home, they are higher acuity, more medically fragile than those who are able to live semi-independently in assisted living. So those will be first. Walgreens projects those will all be done no later than January 25th. And then assisted living will start in the middle of next week, and also projected to be done around the first week of February, I believe.
Great, thank you. We have over 65 people on this call. So instead of having a free-for-all on questions, please drop your questions in the chat room, and then I will just read them for Lisa so she can answer those, and we can be as efficient as possible. So question from Jason: can you define essential workers for us, just as you did with critical infrastructure?
So essential workers is, to be quite honest, it's basically everybody else that is outside of critical infrastructure. I suppose that you could say that there are some things that are not essential. I don't know, I'm having a hard time defining it, like salons and retail, because depending on who you ask, sometimes that is essential. But in all seriousness, it's essential workers are a really large category, but they are different than critical infrastructure. Essential workers would be everything from retail to personal beauty and supply, lots of childcare that are not in the school setting, those kinds of things. Not a good answer, sorry. Just a big catch.
And Jason, I can give a little bit of background on that too, because it's something that just as an Amazon fulfillment center, I'm sure FedEx, many of us on here could give that answer. But it was those companies and those individuals that are part of the kind of the ecosystem to help the stay-at-home orders and provide those kind of frontline services. So grocery workers, teachers, et cetera, were all part of that definition. And each state had a little bit of variances on how they defined those, but for the most part, there was some uniform definition. Lisa, another question. I'm not sure you have a crystal ball, but there might be some indicators out there. There's a question about, are we anticipating a drop in supply in early January or February as manufacturing starts to ramp up?
I don't think so. I haven't been notified of any of that. In fact, the only thing we've been told to anticipate in February is either steady state or increase, whether that is increase in production of both Pfizer and Moderna, and or a third candidate, which would most likely be AstraZeneca, coming on market. But I am not aware of any projected drop, and praying that that does not happen.
Not to put you on the spot, Kelly, but you might have some additional insight to provide just from the Pfizer perspective.
Sure. I think I would agree. We should be stable and or increasing. I think where folks have seen somewhat of a slowdown, we've heard from states so far, is just the numbers that have been doled out from Operation Warp Speed out to the states, and what that process and what that timeline has been is not maybe been necessarily what was communicated originally, but that's not a reflection on production. Hope that helps.
Thanks, Kelly. Appreciate you jumping in. Brian has another question for you, Dr. Piercey. It's on the immunity about the 2 different doses. So I believe you stated that there was 90% immunity after the 28 days. And the question is there an estimated amount of duration for the vaccine for the 2nd dose? And I'll add on to that question, because I think you said no one knows yet. How are we going to test that to understand what that duration may be?
Yeah, that's a great question, and somewhat of the $64,000 question, which is this kind of, after you get your 2-dose series, is this a one and done for 6 months? Is it a year? Is it a lifetime? We're not sure yet, and we're not going to know that until we continue monitoring people, both who have had natural immunity through infection and acquired immunity through immunization, to see if and when they become infected again in the community. Now, there's also herd immunity that plays into that, and so that sort of provides protection to the herd, if you will. But the manufacturers and the drug makers are continuing those long-term studies. From a duration of efficacy standpoint, we're past all the safety stuff, but the duration remains to be seen. You know, we know with natural immunity, recently some stuff came out maybe around the 1st of December, that natural immunity appears to now last at least 6 or 7 months. But that might even be longer, depending on how long we can keep these people protected. So remains to be seen. There was some speculation that we might have to do this once a year. I don't know that we know that yet.
Great, thank you. I think that's part of the education process that we'll continue to do throughout this process. 2 more questions. One is, do you have an estimated timeline, realizing that the 3 primary buckets, based upon risk factors? So removing those, I think, from the question, do you have a timeline or an estimate of when the rest of the essential workers would be eligible for their first vaccination?
So before I say this, I will ask you to find a very large grain of salt before I say it, because it's only as good as my crystal ball tells me. But as we're looking right now, based on what we know about supply and sort of what we've extrapolated on uptake, we think we will be able to be done with 1C, so all of phase 1 by the end of the 1st quarter, and then start on critical infrastructure, which is phase 2. And that will pretty much take up the 2nd quarter, and then general public probably starting in summer or Q3. I know that feels like a long way off, but that, I hope is worst case scenario. And as supply chain starts opening up, we can accelerate through that more quickly.
It's always good to manage expectations. Thank you. Another question. As you have the phases, can counties move at their own pace for the phases? So if Davidson had already completed 1A1, are they allowed to move on to 1A2, whereas Dixon County might still be at 1A1? Can each county move at their own pace?
Yes, absolutely. And we want them to, because there are different demographics and workforces in different counties. We want counties to move as quickly as they can when a substantive portion of the prior phase is completed. Now, we actually had discussion just this morning of what does entail, how do you define substantial completion of a certain phase? Because you might have people in a phase that didn't get vaccinated because they were hesitant, and then they're coming back. But so we're sort of taking that as a demand thing. When the phone stops ringing off the hook for 75-year-olds and starts slowing down, then we'll move into 1B, or we'll move into 70, or whatever is next for that county. There are some counties, maybe plus or minus 20, that are already in the 1B phase. We update that list on our website every day with what phase they're in. It's made it a little more complicated because we don't constrain people by county lines, and people sometimes cross county lines to go over there to get it. But yes, they can move through, and we want them to do that to create the biggest swath possible of eligible recipients.
Great, thank you. There's several comments in here thanking you for all of your thorough questions too. I know it's hard to keep scrolling and also providing this great information. And the answer to the most recent question, all of this information is on the website. There's a very thorough plan, and when Dr. Piercey says it's updated daily, I can attest to that because I know our teams are looking at it on a daily basis. And if you have locations in other states, I can also say they're not updated daily. So thank you for keeping us all full of information. I will close out with one last question, and then we can, I think you have to go, but maybe some of your team members are staying on. How can the business community best help you? I think that you talked about the education component of still doing COVID testing. So I think that's something very important. And that many of us are doing as companies, and continuing with the education of the importance of employee testing while not making it mandatory. And two, once we move through these kind of three critical phases of the risk factors, how can the business community best step up to ensure that we are vaccinating as quickly as possible, particularly with some of our larger employers in the state?
Sure, great question, and thank you for asking that. Because the number one way that you guys can help, besides giving your employees the most updated information, because I realize how frustrating it is to want information or want an appointment and not be able to get it. So you are a trusted conduit for that, for your workforce. And so that's first and foremost. But a close second, as I mentioned earlier, is when it is time for you guys to vaccinate your workforce. If you would be willing to be a provider and enroll and do that on site, we would love to have the extra hands. We know that you know your employees and your workflow much, much better than we ever will. And it's going to be much more efficient to do it on site than to send them somewhere else, recognizing that that's not feasible everywhere. But if you can, you don't have to have ultra cold storage in order to do that. The enrollment is going to ask you about your storage capacity, but that is not a deal breaker. So that's another thing you can do. And then something else that you can do is super important is be a model for your community. Just since we've been sitting here, I've gotten 3 different text messages from somewhat random people that I don't hear from very often saying, hey, my mother's eligible at 75, but I'm really nervous. Is this safe? And can I do it? And that may be hard for people to keep top of mind, because particularly in more urban and professional and educated settings, you don't have as much vaccine hesitancy, but there is still a lot of vaccine hesitancy going on out there. And if you can educate and reassure and model that behavior to employees, we're all going to get back to the normal world that we want really soon. And if you have employees in those high risk categories, please don't wait on your critical infrastructure. Send them individually now based on age and or medical condition, and we'll start protecting your workforce even sooner.
Dr. Piercey, thank you so much. I think this has been really beneficial. I'm going to kick it over to Bradley to close this out, but can't thank you enough for all the hard work that you're doing and the dedication to all of our residents in Tennessee.
Thank you, Holly. Thanks, everybody.
Thank you very much, Commissioner. And I'll close out. Again, we greatly appreciate the partnership and your work. I will say that there's been some discussion about a link for employers to register to enroll to provide the vaccine on site. We're going to get that link, and I think we've got most of the email addresses here, but the chamber will really be pushing that out. And Commissioner, if there are any other materials that you want us to work to get out to the business community, we would be glad to do that, and we greatly appreciate your time. So with that, I just gave everybody a few extra minutes. So enjoy your day, and please keep in contact with us if you have any questions or anything else comes up. And thank you all again.